Eric, thanks. That was one of the clearest counterpoints I've seen in a long time. And I want just to summarize what you said, that it was pathology review had some impact, the event rate, low-risk patients, the sample population. I agree with you. It's really unusual to see biopsies not be somewhat concordant with pathology, and the fact that it's usually radical prostatectomies, the Gleason scores, the amount of tumor obviously goes up. So it's unusual to see if, and GPS has some relations here. And then your 20-year data, when do you expect that to be published?
I'm not sure when it will be published. It's already been turned down by one journal, and so we're responding to the critique and going to resubmit it soon.
I know an editor of a journal called Urology that might be able to help you anyway.
Yeah, that's possible. I have avoided publishing important data in my own journal, though. So.
I know, I'm just kidding. I guess one of the criticisms of, and maybe this was in the reviews you got back that you submitted, might be that it's sort of a self-fulfilling prophecy that you're, evaluating the data basically in the same data that you used initially, but you just have a little bit more follow-up. Is that of any concern, or not, compared to what Dan's group has done as a completely different set of data?
Yeah, true, but Dan's group doesn't have metastasis and mortality data at 20 years. And yes, so we can't make a firm conclusion about it because the data is based on the original cohort, and it's an exploratory analysis because of that. Having said that, when you control for all the other known variables, Gleason's grade and PSA and the usual clinical characteristics, GPS does have independent predictive value for outcomes. But beyond that, think about what these genomic tests or these gene expression profiles measure. This is what I think many people are missing about this. Cancer is driven by derangement of the genome. And there are thousands, tens of thousands of papers across all tumors that show that when the genome starts to go haywire, either in mutations or gene fusions that are more typical for prostate cancer, where gene expression changes, that's when the tumors start to become aggressive. So what we have here, and it's not just limited to Oncotype, it's true for Decipher and Prolaris and ProMark also, is that the higher the score, the more genomic derangement you have. And patients with higher scores have worse outcomes. And so this is just an observation. This says that you can take a biopsy and perform a gene expression assay on it, and you can get additional prognostic information about what's going to happen to that individual patient at 20 years. That's a pretty powerful observation. Now, how we incorporate that, I mean, Dan made a good point, I think, which is that, new biomarkers always have to show to be additive to the standard biomarkers, or rather the standard clinical parameters we use. And I agree with that. And these tests do that. They make our ability to predict the presence of adverse pathology, which has been validated in multiple circumstances to predict long-term outcome. To increase our ability to detect adverse pathology by about 15%. So if I were a patient and my doctor, I were relying on my doctor to say, am I safe for surveillance or not? I would want my doctor to make the most precise prediction that he or she can about the presence of things that could affect the outcome there. And so for some clinicians, a 15% increase isn't sufficient to justify the use of a test. In my view, and from a patient's view, I think it is, in the right circumstance. Let me just say one other thing here. I think we've learned in the last few years that these tests aren't useful in patients with NCCN very low risk criteria. Really small volume Gleason 6 cancers, they don't have much genomic derangement in them. And that's the Canary study that we just talked about, I think, is a good illustration of that. I think they're useful in patients who have higher volume Gleason 6 and Gleason 3+4 disease to determine how much genomic derangement is present and what the long-term is.
What the fact that another large study by Peter Carroll was positive, and in my practice, the whole concept of active surveillance is I've said we want to eliminate active surveillance. We don't want to find people for active surveillance, but when we do, we want to classify them as best as possible. And we use PSA, Gleason score, clinical stage, and Oncotype DX and these others add another parameter. And you're right, it's a genetic rearrangement that is present, and it picks up, and it does add a factor. And I found it, and I'm sure a lot of people have too. The other issue is that if you look at large series of active surveillance patients, a lot of them crash and burn 30% or more and get another therapy. Right. And I think that this matters. And I think the other thing is these are all good clinical trials. They provide level 1 evidence, and we know you and I were in SWOG for a long time together, and we did a lot of trials. And we remember that MVAC trial that was we worked very hard to show that neoadjuvant MVAC did have an impact on outcome in bladder cancer, where patients underwent a cystectomy, but when it was presented at ASCO, it was sort of turned down because of the way the p-value was measured, and yes, not one-sided versus two-sided. Now, fast forward 10 years, and neoadjuvant chemotherapy has sort of become the standard again. So I think we'll find that there's a lot of good in Dan's trial, but we need to. I need to look at it in some more detail as you did, and I really appreciate your dissecting out these things, and look forward to your publications coming out. I think they'll be very helpful in clarifying this. Any parting remarks at all, Eric?
Some ideas come along before their time, before the world is ready for them. The MVAC example was a good one. Now we get a hard time from our medical oncologists if we don't refer the patients for neoadjuvant chemotherapy, even though they didn't accept that view in the beginning.
It is sort of not comical, but it is unreal that how the criticism was there and then all of a sudden becomes the standard. So you just have to sit around long enough. Eric, thanks for taking time from your busy schedule to share your views on this. These are important studies, and urologists need to embrace markers more. We need to educate urologists. We're way behind other specialties in the use of markers, and so we got to keep this moving forward. So thanks for your time.
All right, good to talk to you.